Welcome to The Explainer. Today, we're tackling a huge challenge: medication adjustments and safety protocols in geriatric heart failure.
So, how do you actually treat a failing heart when the patient's entire body is already frail? It's tough. Forget classic shortness of breath. Older folks, they'll often just show up confused, extremely sleepy, or even fainting.
And listen, never just brush off severe fatigue as normal aging. It's a massive red flag for low cardiac output.
Swollen legs? Before jumping to heart failure, always check for sneaky culprits like venous insufficiency or chronic kidney disease.
Now, the medication puzzle. Extreme polypharmacy is a real nightmare here, creating a huge compounding risk of drug interactions.
Because of this, standard hitters like ibuprofen and digoxin absolutely require immediate, heavily tailored dosage reductions.
But get this, for patients over 75, MRAs are a magical exception. They stay highly beneficial for cardiovascular outcomes.
Got a diabetic patient? Always prioritize metformin. Avoid sulfonylureas entirely because they carry a scary excess mortality risk.
Let's pivot to safety protocols. Do we always put these older patients on strict fluid restrictions?
Actually, no. You often need to liberalize fluids for older folks, especially if they have dementia. Wild, right?
But definitely monitor their fluid balance like a hawk if they're taking both diuretics and SGLT2 inhibitors together.
Also, take orthostatic hypotension with a grain of salt. In seniors, it doesn't automatically mean true volume depletion.
Zooming out, frailty is super common, but here's the good news. Early cardiac rehab can actually reverse it.
If they've got cognitive impairment too, you absolutely need heavily tailored self-care support and tight specialist team follow-ups.
Now, what happens if the heart failure is actually driven by a structural issue, like severe aortic stenosis?
For folks over 70 sitting at a moderate to high surgical risk, open heart surgery just isn't the standard anymore.
Instead, TAVI, or transcatheter aortic valve replacement, is your go-to. It is a much safer, recommended alternative here.
Finally, if they have multiple comorbidities and a poor prognosis, we really must consider early palliative care interventions.
Why? Because at this advanced stage, making symptom relief and quality of life the top priority is the treatment.
So, when adapting these protocols, ask yourself, are we just treating a disease or the actual human being?